Okay, so we have a few more that are going to log on shortly, but I'm going to go ahead and get started because we have a lot of people and a lot to talk about today. So welcome everyone. My name is Sarah Meanirod and I am the PBRN coordinator with DO-Touch.NET. Thank you for joining us for this month's episode of Let's Talk About OMM Research. Before we begin, let's take a moment for the housekeeping rules of the webinar. If you have technical issues during the webinar, please send a message to me, Jane Johnson, or G. Franklin, and we will help you. If you have questions or comments during the presentation, please feel free to type them into the chat and to address each other's questions and comments there as well. After the presentation, we will have time for discussion and questions. If you would like to speak during the discussion, please raise your hand and we will unmute your microphone. And we ask that you briefly introduce yourself, and you can feel free to turn on your camera if you wish. When contributing to the discussion, please limit your microphone time to 3 minutes to allow everyone who wants to participate in the discussion to take part. Please keep in mind that this webinar is being recorded and will be placed on the public DO-Touch.NET YouTube channel. And while this webinar is not for CME credit, we would still appreciate your feedback in the program survey that will be emailed to you this afternoon. So today is our Let's Talk About OMM Research educational webinar with Dr. Francesco Cerritelli. Dr. Cerritelli received his degree in neuroscience at the University of Chieti, Pescara, is the president of the COME Collaboration, which is a nonprofit research foundation, and is a research fellow at the Australian Research Centre in Complementary and Integrative Medicine at the University of Sydney. Dr. Cerritelli has a broad interest in osteopathic research, in the study of neurobiological mechanisms of touch, in the study of the role of placebo in manual medicines, and the analysis of the effects of new therapies and health systems focusing on the interdisciplinary aspects of evidence-based medicine. He directs many multidisciplinary research groups in Italy and abroad to innovate and produce robust scientific evidence to complementary therapies. He has authored numerous scientific publications and monographs, and he has been actively engaged in osteopathic clinical activity since 2005. Please help us welcome Dr. Cerritelli. And you should be able to share your screen now, Dr. Cerritelli.
Okay. So thank you very much, Sarah, for this nice and kind presentation. I'm very glad to, okay. Now you just give me a feedback if everything is working correctly.
Yep, we can see your presentation.
Excellent, thank you very much. So again, thank you very much for inviting me to the DO-Touch.NET webinar, and I'm very pleased to be part of this growing community all around the world, and also for being part of this community so far. So today's webinar will be talking about brain-body interactions and how we can, through the use of OMM, so osteopathic manipulative medicine, we can interact with brain, body, and the brain body, so both together. So we'll be going through a few concepts before getting into the OMM in brain-body interactions. And in starting doing so, I would like to start with the concept of interoception. Why? Because the concept of interoception back in the day, so more than 20 years ago, was reframed by Bud Craig, a neuroscientist based in Texas, as the sense of physiological condition of the entire body. Now, the interoception then was taken as one of the leading elements of neuroscience. In particular, into the study of how the brain and interact each other. So, because before that concept and how that concept was reviewed, interoception was based on the previous concept of the 20th century by Sherrington. So back in 1910, where Sherrington defined the interoception as the perception from the, but it actually wasn't that way, because interoception is the way in we heal the entire body. So, and indeed, when we ask to a patient, how do you feel? Actually, we are asking an interoception question. Why? Because we are asking to the patient, doing an endogenous or an inner scanning of his, and reply to this scanning, to this action, by saying, okay, I'm okay, or I'm not okay. Why it's not okay? Because actually there are several elements or several parts of the body that actually, as we say now, they become visible. So pay attention, so are salient to the attention that we are paying to those elements. So, and this is extremely an important concept, because actually the interoception, as we can see from this paper in Nature Review Neuroscience from Damasio and Carvalho in 2013, interoception is extremely linked to the brain with interoceptive maps that are completely different representation in the brain as compared to the exteroception, the usual exteroception senses. And those elements are important, in particular the interoception, because actually they produce action programs that drive the feeling and drive the construction of the emotion that actually goes back to the body, and we can feel emotion, we can feel the feeling inside our brain. That's why it's extremely important to identify and to recognize the fact that when we think about the brain-body interaction, actually we are thinking about interoception and how those elements are, the brain and the body are intertwined, highly intertwined together. So we have two components, so the organism or neuron interior to the neural core, as we said, and then from the neural core, so from the brain to the periphery and back again. Now, very recently, so last year, another paper from the same author actually starting arguing that the interoception is not just a process, so it's not just the physiological senses, but those physiological senses is constructed by a specific nervous system. And indeed, they mint the term of interoceptive neuron system, which is a large collection of neural structure, including viscerosensory, somatosensory, autonomic, peripheral, and also central structure that cooperate in order to produce a real-time, ongoing mapping of homeostatic state of the body. So in the end, the interoceptive nervous system is monitoring second by second in a kind of cinematic way this of the body, and all the interoceptive system is orchestrated by the autonomic nervous system that is including automatic response thereto. But in addition to all these elements, it's actually important to recognize at this point, because all the OMM paper that we're going to discuss are referring to these elements that we are talking here, in particular the insula and the anterior insula, are also important for something that is called allostatic. Allostasis is the term that actually should replace the homeostasis, because it gives the dynamic interaction of the continuous monitoring of state of the body. Indeed, what actually recently has been suggested that allostasis, includes the prediction of homeostasis condition. What does it mean? It means that our brain is set in order to predict what actually is going to happen, rather than to respond to external stimuli. And this is a very big shift, because actually, in particular, what actually is Friston and colleagues are saying with the free energy principle and the active inference principle, that actually our brain is based on not to a specific somatosensory response to the external world, but actually is constantly predicting what should be in what is called a sensor perception action loop. That therefore it creates what actually is the actual called the diachronic allostasis, where is the associated learning between the internal and the external states in order to create future-oriented behavior in a sort of an anticipator and counterfactual prediction error way. So this is a very big shift into the prediction and the interaction between brain and body that actually it's not the brain like a static element, but is a constant anticipatory element that actually is predicting what it's going to be. And this is a continuity process between the subject, that is the brain, and the object, that is the interoception, that includes obviously homeostatic bodily states. And these elements are all intertwined together, as you can see from the pictures from Preston 2021. And all those elements actually creates different models, because we have the models of interoception that it goes from the internal state to the subject, that is the brain, to the models of body regulation, in order to create a models of forecasting, so a prediction of all those actions of the body that might predict, they might change the interoception. So it means that actually we can predict, for example, that we need to increase our HR, so heart rate, before we starting, for example, doing going up to the stairs. So it's something that it's a conservatory, but at the same time is again a prediction loop in order to save energy to the body, and therefore it says minimize the free energy. So how touch can be included into all these elements, and how touch can interfere with all these elements. It can be of help of all these elements in terms of brain-body interaction. So it is based on what Craig back in 2009 in this beautiful paper published on Nature Review Neuroscience, says that all the information from the CT fibers that now are very well-known fibers carrying the information from affective touch, so from gentle touch, that is usually what actually we use in our clinical practice, and it goes directly through the spinal thalamic tract, it goes directly to the posterior insula, and those representing the primary interoceptive representation stimuli that obviously include touch. And in these, just in the posterior insula, we predict, we hypothesize based in 2017 in a paper published in Neuroscience Biobehavioral Review that the insula hosts what is called the affective homunculus. So the homunculus, so a representation of the affective touch that is based on the rate of the number of receptors, CT fiber receptors in the body. So in this process, so from posterior to mid to anterior, as you can see, the insula is the primary interoceptive representation stimuli are enriched of other information that comes from homeostatic motor function, from example, the hypothalamus and amygdala, so from entorhinal and temporal poles in terms of the environmental condition, hedonic condition, nuclear accumbens on orbitofrontal cortex, and then up to the end and the social and cognitive conditions. So in terms of anterior cingulate cortex, the ventromedial prefrontal cortex and the dorsolateral prefrontal cortex. So what does it mean? It means that actually we can interfere with the perception of ourselves even before the consciousness of that, because to make it conscious, from the anterior insula, we need the help of the orbitofrontal cortex in order to make everything conscious. So in a way, through the bottom-up condition, we can modify the interoceptive stimuli, the interoceptive input, and then modify, therefore, the interaction between brain that we are touching through our manipulation, through our touch, and directly the brain. So how OMM can interfere or can interact with the brain, with the body, and the interaction between brain and body. So by this end, we can start using several papers of my group in regards to the fMRI, brain science, and other neuroscience conditions. So in this paper from Tamburella in 2019, actually was demonstrated that an immediate treatment of on healthy subjects, a treatment produce an immediate reaction in terms of a posterior singular cortex and in particular the amygdala, and in primary motor cortex. So it seems that immediately in healthy subjects, so volunteer healthy adult subjects, there is a kind of specific reaction, in particular in the PCC, so posterior singular cortex. Then in this other paper that we published a couple of years ago, we look at the effective connectivity. So how was the connectivity between different brain areas in regards on the same subject? So this is, again, this is called a functional connectivity. And we look at how much which are the brain areas that are important in changing the network between different areas. And actually what we found that the amygdala is playing a very big role in that, and also the left caudate and the some elements of the cerebellum. In addition to that, because actually here we are just looking at the brain effects, what actually we included was a body research where we use thermochams, where we use GSR, so galvanic skin response, and where we use heart rate variability for matching for assessing the effect of autonomic nervous system. Why autonomic nervous system? Because it's the output of the interoceptive nervous system. Therefore, we are just rationally looking at the output of something that actually we implied is included and is involved, engaged in the potentially in osteopathic treatment. So what actually we found that the osteopathic treatment, confirming previous papers, so has got an hyperparasympathetic effect, as demonstrated by the linear and non-linear dimension of the heart rate variability. And on the other side, we confirmed that by using thermochams, as you can see from the picture on the bottom left, as compared to a control group that actually is receiving just touch without any intention. And on the other side, we saw also a change in galvanic response. In this case, what actually was interesting is that we got a kind of a sympathetic activation in the galvanic response, meaning possibly that the osteopathic treatment peripherally is going a cholinergic effect, because the sympathetic in particular in the arms and legs is using both the cholinergic and adrenergic system. So it seems that at the end, to sum up, that peripherally we have a cholinergic effect that actually is supporting the hyperparasympathetic effects demonstrated in other paper. So in this case, so in healthy subject, we saw that actually we had some elements of the brain connectivity that might be referred to the interoceptive nervous system, and on the other side, peripherally, actually we confirmed the fact the autonomic nervous system seems to change after treatment. So, but how we can put these elements together? So in this paper with chronic low back pain patients, we tested the interoception correlates. So just to start making the link together. So we randomized 32 people, and then we got 4 sessions once a week, either on OMM, OMT, or sham. So exactly the same, using the touch equality assumption. So exactly the same time of touching, but without applying the specific approach. And then we have 3 time points for functional MRI assessment. So, and we use a block paradigm, an fMRI block paradigm, block design, where we ask the patients to hear the sound in the earplugs and count the number of beeps receiving. And on the other side, we ask the patient to make an internal or covert endogenous attention by counting their heartbeat without touching the heart. So that it's a typical 2 typical tests for interoceptive sound and interoceptive, the heartbeat. What we found was, interestingly, that we saw after after the treatment, so at 1 month time, we saw specific activation of the interoceptive conditions that were definitely more strong in the OMT group rather than in the sham group. So in particular in the right and the left insula, in the right cingulate cortex, in the right mid-frontal gyrus, and in lentiform nucleus. So what does it mean there? It means substantially that in chronic pain patients, the activation of the through pain and due to pain, the activation of the brain is definitely higher. So they start from a higher situation of brain activity. Why? Because actually they are feeling a lot of pain, so they have a lot of rumors inside the brain. So treating those patients actually reduce those elements, improving the quality of the network, and therefore improving the quality of the perception of self. Indeed, this condition is very well known in the clinical practice when people start saying after the treatment, oh, I feel better, and actually I can recognize something, or I can respond better to stressor, outside environmental stressor, or for example, I'm more relaxed. So why is that? Because actually we are interceding through the body, we are interceding and interfering with the interoceptive condition, in particular in those areas. In addition to that, what actually we found that people who were treated after 1 month actually were more precise in detecting their heartbeat. So they made less error, lower error in terms of the number of heartbeat counting, because actually we were using plethysmography to check the precise number of the heartbeat per minute while doing the all the paradigm, FM paradigm. So in addition to that, what actually we did, we added also another element that is related to how the brain and body are interacting each other. How we set that on the same patient, so chronic pain, we tested the cerebral blood flow, so the amount of blood coming to the brain, and on the other side we checked the heart rate variability. So in this way, actually, we combine the 2 things. So we look at the brain-body interaction. What actually we saw on the same structure and settings of the previous study, that we identify several areas of the pain matrix actually reacting nicely to the osteopathic treatment by reducing their activity. So it means again that the brain is better, it creates a better environment by reducing the activity in those areas that actually are too much activated due to the pain. And that actually is linked also to the assessment that we use in terms of the visual analog scale. Indeed, by using the visual analog scale, we correlate specific areas that we saw earlier with the changing of the visual analog scale before and after the treatment. So it means that actually, if we want to use the visual analog scale in the clinical practice, treating those patients with chronic low back pain between 30 and 55 years old, we can predict if the reduction of the visual analog scale is the one showed in the in those graphs, that actually we can have also an effect, a specific effect on those areas that actually are related to pain and to interoception. In particular, there are positive correlation, for example, for the left insula, and for example, negative correlation for the left posterior singular cortex or the left anterior singular cortex. In addition to that, anyway, what we added, so as we said, we measured also HRV, so heart rate variability. We saw again, we confirmed also for the first time, we confirm in chronic pain patients that actually there is an hyperparasympathetic, again, hyperparasympathetic trophotropic effect of the osteopathic treatment, but very interestingly matched these elements with the CBF, so the cerebral blood flow values on specific brain areas. And what actually we found, again, inverse correlation between the HF, that is the high frequency, a usual frequency domain for measuring parasympathetic effect, as compared to the low frequency, a usual frequency domain for the sympathetic effect, measured in normalized units. So again, it means that if we can use a normal HRV tool that can be also a watch, we can instead predict how the brain might react. What actually we found in that way, so we use those elements also to give to clinicians some instruments that actually they can use in the clinical practice. In addition to that, what actually was another element that I'd like to introduce here, and then I'm going to finish, is how the brain just the touch, the continuous touch can change the brain even before the subject can realize that. So in this way, actually, we included 40 healthy right-handed patients between 18 and 50 years old. We continue static touch on the malleolus, lateral malleolus, and while touching, they were scanning. And the operator was randomized into a operator tactile attention. So the operator was paying attention to the hand, and on the other side was on operator acoustic attention. So the operator was instead focusing on the beep going to the earphones, and the beeps actually were random. So the operator was paying attention to the number of and counting the number of beats. What actually we found is that after 5 minutes, after 10 minutes of touching, those who were receiving, those subjects were receiving the tactile attention, the operator tactile attention group, actually starting to predict or started to fire with the bold analysis, in particular the right insula and the right inferofrontal gyrus, that actually are extremely important for, again, the prediction of the interoceptive conditions, and therefore it means that the patient was starting to change something in him or herself, but not again realizing what is doing. So it's a kind of, again, interoceptive prediction changing based on environmental changing. Obviously, as you can see from this table, there is no difference in terms of touch perception from the two groups. So the two groups actually were similar in terms of the type, were scored similar in terms of the type of touch received. So how these can be summarized and then ended up with the new concept that we are developing right now. So we said that in chronic pain patients, there are specific elements in terms of the interoceptive brain areas that actually are activated after 4 osteopathic treatments, and this actually is also correlated with specific brain pain areas using CBF. Instead, in the other study, we use both activities. And this condition with the change of cerebral blood flow is also related and correlated with specific HRV, so heart rate variability changing. So how that implies into clinical practice. So if based on the study that we published early this year, it means that if we have an expectation of something, so let's make the case of a patient with chronic pain, chronic low back pain, that is the case of this figure here. So the patient actually, and we ask the patient to go into flexion, and then the patient knows that going into flexion create a pain. So what actually he is doing is predicting that the flexion will create pain on movement. So why is that? Because we minimize the prediction error. We predict that actually it's going to be a muscle span, and these actually will confirm the prior, so will confirm the expectation that we had, and the loop. And the cycling loop, the visceral cycling loop, starts again. But if we treat the patient in a way that actually is modifying the interoceptive condition and obviously pain, when actually we ask for flexion, the prediction error is creating no pain. So it's in a way it's surprising the system. So we have a high prediction error, so we don't expect that. So we create no pain, we create and we fire new prior, and this new prior is changing the network. So we create again a surprise for the system, that it goes away from the prediction that the system had, and this actually will restructure the entire system. So, and why is that? Because actually we use an action perception loop, as we said, that it's based on active inference, where the sensation again minimize the agent's bound on surprise, and the action is used for optimize the agent's bound on surprise. But these actually will interact with the environment and the niche constructed by ourselves. But when actually we use and we come with patients into the osteopathic clinic, there is an agent patient, there is an agent osteopath, and this action perception loop is intertwined. And in a way, actually, we can create a way to surprise the system. We can definitely change the brain. And all these elements are theorized in several papers that we published this year in order to create an engagement between the patient and the agent patient and the agent osteopath in a way that actually are the people and are synchronized and create a way to change the way in which the patient is seeing the environment and perceiving herself in more precise, predictive way. So I would like to stop here, thanking all the team and acknowledging all the team, all the people working with us within all these papers and all the papers to come. And I would like to thank you all for listening to me. And I'm very pleased to open the discussion with the questions.
Thank you so much, Dr. Cerritelli. This was incredibly interesting. So just a few reminders as we open the floor for attendees to ask their questions and have discussion. If you would like to speak during the discussion, please raise your hand and I will unmute your microphone, and we ask that you briefly introduce yourself, and please feel free to turn on your camera if you would like to. When you are contributing to the discussion, please limit your microphone time to 3 minutes to allow everyone to have the opportunity. And us as monitors, Jane and G and I, we're happy to read your questions in the comments if you would prefer to type them into the chat. You can also address each other's comments and questions there as well. And just as a reminder, because this is the first time we're doing this setup, this is being recorded and will be put on our public YouTube channel. So keep that in mind when you're asking questions. So does anybody have a question for Dr. Cerritelli? It looks like, to start off, Dr. Degenhart has a question in the chat, Dr. Cerritelli. So it says, there is recent evidence that chronic pain causes inflammation in the area of the brain that is receiving the barrage of impulses. Are you aware of this research? And if so, what implications do you think this has for future mind-body research related to osteopathy?
Yes. So thanks for the question. We can answer this question in several ways. So by using what the concept that we shared today, and this actually implies that those areas who fired or who are more active are those who definitely lead different pain networks. So in a way, they are restructuring the brain by having them in. Oops. By having that creating them into the function of the brain. Now, in case of chronic pain and how the papers that we saw, some of them are based on chronic back pain patients. It's seen that the OMM can interfere into the restriction of the brain network by possibly using the interoceptive afferents, in particular those related to the CT fibers that actually run through the spinal thalamic tract and goes up to the insula, and that in the insula is seen as a key area for pain, but not only for pain, also for the management of pain. That means how the interpretation of pain, so how the people can interpret the pain based on the perception that they have. So it's a kind of a collector of information down there that is going always firing, and indeed several papers also based on interesting prediction of how the brain is growing. See that the insula is the only area in the brain that doesn't go into pruning. So that means there is a kind of brain elements that is always checking how the brain and the body are going.
Thank you, Dr. Cerritelli. We have another question from Dr. Downs in the chat, and he says, how do we know that the SNS is in the nervous system input is responsible for interoception? I don't doubt it, as I remember a presentation by a spinal cord injury patient who could monitor his body distal to his cord injury level.
No, so the autonomic nervous system is the output of the interoceptive nervous system. So by ages, actually has been thought that the autonomic nervous system was doing both, but actually it's not. So the interoceptive nervous system is, in particular through the lamina 1 and the spinal thalamic tract, so C fibers, are actually going through all the way up and stopping into also the autonomic centers, that is in particular in the brainstem and in the diencephalus and in the encephalus so far. So by receiving all this information, and the C fibers actually are carrying homeostatic information as discovered by, as said and stated by Craig back in 2002. And those information are related to, for example, cell rupture, mast cell activation, or histamine, and pain, and cytokines, and all different interleukins, so pro-inflammatory or anti-inflammatory substances. So when there is a tissue insult, all those information are taken by the C fibers, and then there is a long arch reflex that which the output is the autonomic nervous system directly in that area. So that's why the spinal cord injury patient can still feel himself or herself by the fact that probably some of the C fiber were not cut, for example, or were still functioning. Or again, there is the possible, let's say, mental imagination of the perception of himself or herself down to the spinal cord cut. I hope I answered the question.
Thank you, Dr. Cerritelli. That's all the questions we have in the chat. Does anybody have a question they want to? Jane, it looks like you have a question.
So yeah, a question from a statistician. So take that as it comes. So I was curious the results that you had about the continuous touch. Do you see that having implications for developing sham treatments for research? Because, you know, we have studies that use light touch, for example. So I was just curious about that. Yes,
yes, Jane, thank you very much. Very appropriate question. Yes, indeed. And that's why in the years after that paper, actually we started looking specifically on the control group, because one of the main elements and the main problem that we have is that we focus on the intervention group without paying too much attention to the control group in terms of what is the amount of touch that the control group patient receive, the type of touch they receive, and instead, indeed, last year actually we published this paper that is the 5 challenges in osteopathic manipulative medicine for the clinical trials, where actually we hypothesize that it's extremely important what is called the T, so the touch equality assumption, TEA. That means that the 2 groups has to receive exactly the same amount of touch, but with no specificity for the control group. So we are just checking that the 2 groups receive exactly the same amount of general touch, without the specific effect, or what actually we want to test. That is the specific effect of the osteopathic treatment so far. So, and why is that? Because it's known that the osteopathic the touch in general, effective touch or static touch, or dynamic touch, gentle touch, produce an effect in the body by first activating specific part of the body, including the insula and other areas of the limbic system, and second actually is extremely related to pleasantness. So meaning that actually if you receive a care from someone you like, or in general you receive, and the care has got specific dynamics, so between 1 and 10 centimeters per second, it fires the specific CT fibers in a way that actually are directly related to the insula and are directly related to pleasantness. So that is completely different from having a touch like this, that is not pleasant at all, but a touch like this one that is similar to, for example, the care and the cuddles that a mom gives to, for example, a child, in particular in the head and in the back. It's producing pleasantness and it's producing calmness, because actually it also reduces the heart rate. And we saw also we demonstrated that also on preterms that actually increase the oxygenation of the preterms itself.
Thank you, Dr. Cerritelli. So there was a question in the chat that asked if we could see the fourth slide again. It's the 3-level flow chart. That may or may not be the fourth. And then while you're finding that, we have another question. Can there ever be a touch sham? Is touch always an alternative treatment?
Good question. So let's start with the so we need to understand, probably we need to clarify one thing. So if the sham, it means that the sham, we are using the sham versus an intervention. So meaning so far that the what actually we can test is the touch as comparing the osteopathic intervention. If we want to use for example, a touch sham, yes, we can do that. For example, in virtual reality, so we can see the way in which we can touch people, but actually we are not feeling that. And it's the way in which we can predict that someone is touching us, but actually it's not. And therefore we can have, for example, a touch sham. This is similar to what in neurology or in neurorehabilitation is based on, for example, mirroring. So that is recent findings matching the neuroscience effect of the mirroring therapy and mirroring neurorehabilitation and the touch new discoveries so far. So the third, is that one, or is
I think
one?
they're asking to see the third slide. Yeah, okay, go ahead, sorry.
Oh, is this one?
Yep, I think that's the one he wanted to see, yes.
Okay.
So then we have another question in the chat. If you have a question that you want to ask on camera, just raise your hand and I'll be glad to unmute you. But we have another question in the chat, and it says, since you have done research on neonates with very newly developed central nervous systems, do you see opportunities for continuing this line of research in neonates?
Yes, thank you for the question. So we just set up a big trial on neonates measuring fMRI, so using fMRI, EEG, and metabolomic. So we are just in the process of starting the trial and looking at the effect of osteopathic treatment using fMRI, EEG, and metabolic effects. Yes, of course. Yes.
Beautiful, thank you. All right, so this next question is, how do you obtain funding for your studies?
Good question, Michael. So the collaboration that we have, should I stop sharing the screen or I should keep it up on?
You can stop sharing, that's perfect.
Okay, so otherwise I can't see you. Anyway, so it depends, because actually the majority of the study that we have done are in collaboration with universities or in collaboration with public hospitals so far. So through them we can apply to different national or ministry public health fundings, or there are other foundations, for example, private foundations that are interested in looking at the effect of touch in particular on, for example, on neonates, and therefore we apply for fundings for that.
All right, it looks like we have somebody with their hand raised. Oh, where'd he go?
Yep. Oh, I'm here.
Oh, there
Sorry.
you are.
I lowered my
Okay.
hand.
Go ahead.
Hi, I'm George. I'm a first-year ethics student at Des Moines. And I was curious about for the OMT versus placebo trials that you published in the last couple of years. Curious what or inclusion or exclusion criteria were for those, and was there any consideration for gender, sex, and sexuality of the patients and the practitioners? I know that's been a recent thing with mice or rats, so I was kind of curious how that played a role here.
Okay, so thank you. Would you mind to repeat which paper so far, please?
Yes, I have. It was towards the end, you were showing some OMT versus placebo with brain imaging, and I did not jot down the names of the papers, unfortunately.
Okay, so the one is the one on continuous touch or the...
I think that one, yeah.
Okay, so healthy subject, continuous touch.
Yes.
Okay, so no, they were equally distributed. So the 32 were pretty much equally distributed in terms of gender. So, and actually we didn't went through a gender analysis, although it was interesting. Thank you for the question. Why? Because actually the number was pretty much low so far. And we saw that in particular in previous studies looking for touch, there weren't that much difference in terms of gender effect.
Okay, thank you. Is it the same for the osteopathy modulates brain-heart interactions in chronic pain patients as well?
Pretty much the same, yes. And okay, what actually we have implemented in that paper is that we use gender as a cofactor, so a confounding factor in the analysis. So rather than subdividing them into two different groups, so male and female, we use the gender as a cofactor into the analysis, and actually they didn't change much.
Cool, thank you.
Dr. Cerritelli, we just have a comment in the chat, not really a question. Jane says, I have thought that several control levels would be helpful for OMT clinical trials. A pleasant or light touch, which is active control, spending time but no touch, attention placebo, and no contact, waitlist, conventional care, or something like that.
Yes, thank you, Jane. Absolutely appropriate. And I was part of an international group on creating guidelines for controlling for placebo and sham therapy on non-pharmacological trial. So a paper that should be out on BMJ, British Medical Journal, by the end of this year, hopefully. And yes, you are completely right, because there are different type of control groups that actually we can use, but it depends obviously from the research question. So, and based on what actually we want to control and what actually we want to highlight from the from the intervention group so far. So, if we are, for example, looking for the effect of osteopathic treatment on concentration or ability to decode interoceptive interoceptive stimuli through, for example, patient-reported outcome measures, so questionnaires, surveys that are specifically identified for that. Yes, a control group for, as you said, attention placebo is definitely appropriate so far. So based on that, the type of control is absolutely relevant and super important if we want to have reproducible and in particular valid results.
Thank you.
Does anybody else have any questions or comments for Dr. Cerritelli? We have about 5 minutes left. If you want to put them in the chat, I can ask them for you, or you can raise your hand and I'll unmute you. So we have a question here in the chat. It says, hi, Francesco, regards from Brazil. from Dr. Nessie, and I would like to ask if you believe that these new concepts can introduce a reconceptualization of osteopathy, and if so, how would you see it?
So thank you, Jason. Yes, I think so, or I hope so. Why? Because actually we can use this concept to interact better with the patient, not just from a mechanicistic point of view, but more from an active perspective. And therefore, in a way that actually we include the patient operator niche. So, and we can optimize the relationship with the patient, not by using our way of, okay, I'm applying this technique, applying these procedures, because I think it's useful, but on the other way, we are looking more to a real patient-centered way, a conceptualization of the osteopathic session, which actually is also in line with the very new concept of neuroscience and behavioral science so far.
Dr. Dean, you want to close us out with a final question?
Hi, thanks for taking my question. It's kind of a general question. So there's a lot of debate, it seems like, that like in the United States, of protocol-driven research versus kind of treat what you find. And I know with the NICU studies, a lot of it is you're treating the somatic dysfunctions that you find, which seems more patient-centered, but a lot of the MDs in the States don't understand that model. And I just wonder if you have any insight to share to kind of help bridge that and help people here understand why that needs-based and treating what you find is you know a good way to go, if that makes sense.
So, of course, I mean, and I think thanks for the very appropriate and up-to-date question so far. Now, it's mimicking the clinical practice, right? So in the clinical practice, usually you don't treat by protocol, right? Because we all us know that we can't use exactly the same protocol for different patients, right?
Right.
Because actually the patient comes with a different story, with a different environment, with a different situation, with a different clinical condition. So the symptom might be similar, but the clinical condition might be different.
Wow.
So therefore we are moving towards what actually is comparative effectiveness research or pragmatic trials, rather than looking at the rather than the efficacy of a technique or a series of procedures.
Okay.
So the idea is more moving towards effectiveness. So the measuring the clinical how the clinical encounter or the clinical practice might change the patient's conditions, rather than looking at for example, the causal effect of one technique or a set of procedures to the symptoms of the patients.
Wow. Thank you.
My pleasure.
Well, Dr. Cerritelli, thank you so much for this really robust discussion and the presentation. It was really wonderful. Thank you so much for joining us.
Thank you.
I just want to remind everyone that our next Let's Talk About OMM Research webinar is next month on December 16th at 12 o'clock U.S. Central Time. And at that webinar, we will have Dr. Regina Fleming, and she'll be discussing Parkinson's disease and OMT. And also, just as a reminder, our annual meeting is coming up, and we also have a residency enrichment program coming up in March as well. And we would like you all to join us for those two events. I hope to see you next month on December 16th. Thank you all for joining us. This is really wonderful. Thank you, Dr. Cerritelli, again. Everyone have a wonderful Friday.
Thank you very much. Thank you for inviting me, and thank you everyone for staying here.